begin. So I'm very happy that we were able to invite you to this Grand Round series, our third Grand Round series in cardiovascular imaging here at the University Hospital Zurich in Switzerland, which we organize together, the Department of Radiology and the Department of Cardiology. Jan Bogaert is an expert in cardiovascular imaging with a enormous also scientific career. A well-known speaker at international conferences. I saw him recently at the ESCR meeting in Dubrovnik. So we are very happy that you are today with us, and you will present us your experience and your opinion about imaging of patients with pericardial disease. Thank you very much, Jan.
Thank you, Hatem, for this very kind introduction. And also, for me, it's an honor to participate to this series of webinars with really highly esteemed speakers. And as Robert introduced me during at the last webinar, he said that I've been involved in cardiac imaging for years, and he was correct. I've been interested in mostly CMR for more than 3 decades. And for whatever reason, I always have had a high affinity with pericardial diseases. And I think if I look back, my very first publication on pericardial diseases was published already in 94 or 95. And let's say the next 35 minutes, I will entertain you with a structure that in normal conditions is hardly visible. So if you look here at the CT images, this is this very thin line. And we can see it because it's rounded on CT by the epicardial and the mediastinal fat, and we recognize it as this thin line. Nevertheless, it can be the cause of significant morbidity and also mortality. And pericardial diseases are not exclusively part of cardiology, but also recognized in patients, or can be found in patients with systemic inflammatory diseases, with infectious diseases, and also oncology. The symptoms, okay. Could you understand me? Yeah, okay. Now you see me. The symptoms are variable, and because they are not always directly linked to the pericardium or suspected for pericardial diseases, imaging is really crucial. And if we look at the different imaging modalities, the first in line is definitely still cardiac ultrasound. It gives us, let's say, already a good knowledge interpretation of or whether the pericardium is abnormal. But let's say CT and CMR have become definitely also prime players in investigating patients with pericardial diseases. If we start with CT, you can do CT scans before and after contrast. And what they do is they allow to visualize the pericardium. You can see if there's effusion present, you can measure the width, and they are definitely the best technique to appreciate the presence, the spread of pericardial calcifications. Next is that you can look at the rest of the heart. You can look at the liver, the inferior vena cava, look if they are abnormal or not. And if you, let's say, irradiate the patient of the entire cardiac cycle, you can also make dynamic images of the heart, and you see very well here the pericardial calcifications invading the lateral wall of the left ventricle. I will, in one of the next slides, come back on this phenomenon. And the next is CMR. And over the years, where in the beginning CMR was mostly a morphologic technique, over the years it has grown towards what we can call a fully comprehensive imaging modality, where we not only try to image the pericardium, and you can see here that on the left upper, this is the one-weighted spinnacle, you see that the pericardium is thickened, that it has not this dark signal intensity as we normally see, but it is gray, suggestive for inflammation. And this is confirmed on the T2-weighted images here in short axis. We see a very bright pericardium, and on the late gadolinium enhancement, we see the uptake of contrast in both pericardial layers. This with regard morphology and tissue characterization. Next is that we also will look functionally. What about the size of the heart, cardiac chambers? What is their function? Is it impaired? Is it preserved? But also to look what is the impact of the abnormal pericardium on the cardiac behavior. With behavior, I mean the diastolic function. And then we look if and with the what we can call the ventricular coupling is preserved or not. But as I said, a lot of patients are or can be or the pericardium can be involved in the setting of systemic inflammatory diseases, where also the rest of the heart can be involved. So we need also to look at the rest of the heart. And for instance, here you see patients with systemic sclerosis, with severe pulmonary hypertension. You see the dilation and the hypertrophy of the right ventricle with the disc-shaped septum, and also the typical strong enhancement of the hinge points at late gadolinium enhancement. Finally, we can also look or use CMR to look at the indirect consequences of pericardial diseases, such as increased filling pressures on the right side. And we can use the T1 mapping for this. We can do T1 mapping of the liver to see if there are signs of liver congestion. What else can we do is we can use real time of the IVC during inexpiration, look at the caliber of the IVC and see if during inspiration there's a collapse or not. And this is also indicative of increased right filling pressures. So let's start with normal anatomy. I said in normal conditions, the pericardium is hardly visible, and we can't see it because it's surrounded, or when it's surrounded by fats. For instance, on the lateral part of the left lateral part along the left ventricle, often the pericardium is not visible. It consists of a visceral and a parietal pericardium. In normal conditions, there's a tiny amount of pericardial fluid. And besides the, let's say, the main part of the pericardium, we have also this presence of some recesses and sinuses. So we have the transverse sinus, and on posteriorly, we have the oblique sinus. And as I said, we have also the recesses. They are important to know that they are there and not to be misinterpreted by, let's say, abnormal pathology, such as large lymph nodes, aortic dissection, or whatever. But let's say with current high-end imaging modalities offering, let's say, good image quality, normally differentiation is not that difficult. If we look at the functional aspects, the pericardium definitely has an important role, because it has a certain stiffness and it contributes to the overall cardiac stiffness. Next is that it is a kind of intermediate between the changes in the pressures in the pleural space over the respiratory cycle, and they are directly transmitted to the cardiac chambers. What next is that the normal pericardium is really important to reduce the friction and to guarantee a normal cardiac motion. And it also acts as a mechanical barrier to infection. Next is that the pericardium is supported, or there are some ligaments to the sternum and other parts of the chest wall to ensure that the cardiac displacement is as small as possible. And finally, there's also a metabolic role in the pericardium. Let's move to the abnormalities, starting with pericardial effusion. It's considered that if you have less than 50 mils or width, less than 4 millimeters, it's considered as normal. I would recommend, if you measure the pericardial width, also always mention in your report where you have measured it and during what phase of the cardiac cycle. Because typically, if you have an effusion of 4 millimeters in diastole and the heart contracts, it can be 6, 7, or even more millimeters in systole. With regard to the etiology, it's really very wide. It can range from idiopathic to, for instance, aortic dissection. I've just here, we had, let's say, one unfortunate case. There's a patient who underwent a chest CT because of suspicion of aortic dissection. And on the table, he did a rupture of the aortic dissection, and he really bleeded to death. And you see the very high density of contrast in the pericardial sac. So with CT, we do density measurements. And if you have Hounsfield units between 0 and 20, it's called transited. If it's higher, it's suspicious that it contains protein, it may contain blood, and so on. If you have a patient with pericardial effusion, always look to the thickness of the layers, to the presence of pericardial enhancement after contrast, and also to look for the presence of calcifications. With CMR, in patients with pericardial, suspected pericardial disease, in our center, we do the T1 weighted and the T2 steer with a very strong T2 weighting. And you can also describe the presence of effusion on that. And here you see in the right, and it's a bit hidden, you see that the patient has thickened pleural pericardial layers. And in between the pericardial effusion, you see the presence of hemorrhoid of fibrin strands. And what can be helpful is that to use T1 mapping to have an idea about the consistency of the pericardial fluid. And typically, the higher the T1 relaxation time, the more likely is that you have to deal with pure water. So if studies have shown if on the 1.5 the relaxation time is more than 3,000, it's likely that it's a transudate. The lower it gets, for instance, here in this example, this was an example, we measured the T1 relaxation time of around 1,800 milliseconds, and this was a hemorrhagic effusion. So it's also of interest to mention in your report the relaxation time. With regard to cardiac tamponade, it can be quite short. This is a condition where there's an increased pressure to whatever condition. Most of the times it's fluid, but because of the increased pressure, the cardiac filling is impeded. And normally the diagnosis is made clinically or at echocardiography, so there's a limited role for CT and CMR. However, what you can see in patients with pericardial effusion, for instance, as shown here, that during the cardiac cycle, and in this case, it was during systole, that you have a partial collapse of the right atrial wall. Why? Because the pressures inside the pericardial space are at that time point of the cardiac cycle higher than the right atrial pressure. And it's also important to write or mention this in your report. So let's move from pericardial effusion to pericarditis. It's quite common. It's considered that about 5% of patients with non-ischemic chest pain in developed countries have pericardial diseases. It affects young and middle-aged individuals, and the peculiarity is that it has the tendency to occur or recur, sorry. And it can be isolated or it can be part of a broader, more systemic disease. And early diagnosis is really, and correct treatment is crucial. Otherwise, the disease can be prolonged and there's also a higher chance for recurrences. If we look at the etiology, it's once again very wide, but it's considered that in developed countries, after extensive investigation, about 80 to 90% are considered idiopathic, presumed to be viral, while in developed countries, both tuberculosis and HIV are still common causes. If you look at the diagnostic criteria, in acute pericarditis is considered that you should at least have 2 or 4 criteria. So patients present with pericardial chest pain, pericardial ruptures, ECG abnormalities, and a new or worsening pericardial effusion. And supportive is also that your CRP has increased and the CMR marker, it is the presence of enhancement reflecting pericardial inflammation. It can be prolonged, and if it's prolonged, it's called incessant, where it takes longer than 4 to 6 weeks, but less than 3 months. Longer than 3 months, it's considered to be chronic. And the recurrent stages, if after a documented period of acute pericarditis, you have a symptom drug-free period of 4 to 6 weeks. If we look histologically, we have different stages. In a very early stage, it's called the organizing pericarditis. What you have is a lot of inflammation, neovascularization, granulation tissue with fibrin deposition. If not well treated at that time, it can evolve through its next stage. It's called the healing pericarditis of the progressive sclerosing pericarditis. And I try to understand it that in the very beginning, you have a lot of inflammation, but over time, you have an increased amount of fibrosis, and this leads to a decrease of compliance. And this ultimately or eventually can evolve through its a more later stage, which is called the healed organized fibrotic pericarditis, with a lot of fibroblast collagen, with or without calcification. And the nice thing is, if you do CMR, using a combination of T2-weighted images and late gadolinium enhancement images that you can stage. Why? Because in the beginning, and I will take the next slides, here what we see is above there are T1-weighted spin echo images, the T2 stir, and late gadolinium enhancement. On the left is a normal patient or subject, and here you see different stages. Well, with different stages, I mean, if you go from the left to the right, increasing in severity. Look at how inflammatory pericarditis presents on T1. We see thickening of the pericardial layers, and it gets gray. And the higher the inflammation, the brighter it gets. And this is, of course, confirmed by T2-weighted images, which are very sensible to the increase of water, so they reflect myocardial edema. And you see also increased edema. And in important cases, you have edema, as you can see here, of the outer layer, the inner layer, and the black in between is diffusion. And then of the late gadolinium enhancement, we see strong uptake of contrast. Here, for instance, this patient see in this a little bit of pericardial fluid. And then once again, if we move to the left, we see more severe cases. A couple of years ago, we looked what is the relation between effusion, late gadolinium enhancement, and CRP. Why? Because it's written in the guidelines that new or worsening pericardial effusion is a criterion to make the diagnosis of pericarditis. And what our study showed is that pericardial effusion is rather a poor discriminator to differentiate between the presence and absence of pericardial inflammation. However, if you look at pericardial enhancement, is a much better discriminator than effusion. And in the next step, if you divide the patients with pure late gadolinium enhancement without effusion, these can be considered the dry pericarditis or the Zika forms, and compare them with the ones with an effusion. You see that the ones with late gadolinium enhancement and effusion have significantly higher CRP values than the ones that have only late gadolinium enhancement. There has been also some work performed with regard to the role of CMR in relapsing or recurrent pericarditis, and there it was shown that late gadolinium enhancement, T2-weighted images, or the pericardial edema images, and late gadolinium enhancement images are the best to depict a relapse of pericarditis. We have also to be aware that the involvement of the pericardium cannot be as a sole phenomenon, but can be associated with myocarditis. And on the other hand, myocarditis can be associated with pericardial inflammation. So the condition where you have myocarditis with concomitant pericarditis is called the perimyocarditis, as you can see here. In this patient, he has several areas of subepicardial enhancement along the lateral wall of the left ventricle, with also some pericardial enhancement. And the other condition is that you have perimyocarditis, which means pericarditis with concomitant myocarditis. As you can see here, in this patient, pericardial enhancement or diffuse pericardial enhancement with this subepicardial layer reflecting associated or concomitant myocarditis. However, I have to say that this condition, the myopericarditis, is, at least in my experience, quite rare. As I said, pericardial disease may be part of a systemic, inflammatory or autoimmune related disease. And we get more and more of these patients referred for CMR. Why? Because CMR offers a very comprehensive look on the heart in total. Just one example, this was a patient with systemic lupus, and it was not a female. Most of the patients are young or younger females, but this was a man with anti-nuclear antibodies, also positive anti-double-strand DNA, which is highly suspected for the diagnosis of systemic lupus. And he presents with, let's say, an acute inflammatory pericarditis with thickening of the pericardial layers, pericardial edema, strong enhancement, but the rest of the heart looks quite okay. And if we look at the criteria defined by Euler and the American College of Rheumatology, we see that the pericardial effusion and acute pericarditis account, sorry, I have to call one back, account for 5 and 6 points, and you need a total of 10 points to make the definite diagnosis of systemic lupus. Just to mention, just a quick example that pericarditis can also be drug-induced. This patient with pancolitis got infliximab as treatment, and he presents with quite a severe, let's say, an inflammatory diffuse pericarditis, diffuse pericardial edema, a bit of pericardial fluid, very strong enhancement of both pericardial layers. Another condition is what is called the epistenocardic pericarditis, as defined as pericardial injury in acute myocardial infarction. Because if you have an infarction and ischemia does not necessarily stop, let's say, at the border of the outer border of the myocardium, but can also inflammatory or lead to kind of inflammation of the adjacent pericardium. And it's quite a common phenomenon. And the enhancement, as you see here, with a small transmural infarct, can be limited or can be very extensive. So if this patient had a large lateral infarction with a huge now reflow zone, look at the very important enhancement of the entire pericardium with also some pericardial fluid. And typically it occurs in the early stage, very soon after the infarct. And if you do follow-up study, it disappears. And what we have found is that most likely the presence of pericardial inflammation drives the rise in CRP, and not necessarily the rise is caused by the myocardial damage alone. And epistenocardic pericarditis needs to be differentiated from the vesicular pericarditis, which is believed to represent an immune response to damage of the heart. It can occur after heart attack, but typically it occurs only after several weeks. It can occur after surgery or after traumatic injury. Here, an example of a patient with onset of retrosternal chest pain 4 weeks after surgery for a mitral and tricuspid valve repair, as you can see here on this 3-chamber view. And what we see is we see a mildly thickened pericardium, but a lot of pericardial edema and strong enhancement. And this condition should be differentiated. And what we often see, for instance, in heart transplant patients or in patients with coronary bypass or valve surgery, after even years after surgery, that they still have some pericardial inflammation. No pericardial edema, however, some pericardial inflammation. There was a recent paper by the group of Lausanne, and they showed that this phenomenon occurs in about 44% of patients and reflects a kind of low-grade chronic subepicardial pericardial inflammation. And unfortunately, I can say in a small percentage of patients, an inflammatory effusion or inflammatory pericarditis, as you can see here, this patient has on CT a thickening, diffuse thickening, and enhancement of the pericardium, can move, and this was very slow. Often it goes faster, but this is slow. Over a period of 5 years, you see First of all, you see the differences in the heart. It seems to be squeezed. And why is it squeezed? Because there's a non-compliant pericardium surrounded to it. If you look in detail, there are some calcifications, and these calcifications invade the adjacent or underlying myocardium. And on top of it, there are also left-sided pleural effusion. With regards to the etiology, this is a paper, and I forgot to mention the reference, but you can see that often it's idiopathic, but they have other conditions such as post-surgery, radiotherapy, and so on that can cause or lead to constrictive pericarditis. This slide, I can be very short, but just as a reminder that once again, we can use CMR to stage the pericardium. I will show you some examples. But let me start with the diagnosis. The diagnosis of constrictive pericarditis is not always straightforward. First of all, you can use the morphologic criteria, which consists that the main criteria of constrictive is that you have non-compliant pericardium, and it is often thickened, but not always thickened. It can be calcified, but it is not necessarily calcified, and it constricts the heart. Can be focal, can be more generalized. A next criterion is looking at the function and hemodynamics. Is if you have a constrictive pericarditis, this means that cardiac filling is impeded. So we should look at signs that indicate that the filling is impeded. And finally, we have also some indirect criteria showing or pointing that the filling pressures either on the right or the left side are increased. And importantly is that apart from a classic presentation, we have also several what we can consider atypical presentations of constrictive pericarditis. Let me start with, let's say, a classic example. Here we already see on the chest film, on the lateral chest film, you see these typically curvy linear calcifications, which are very well appreciated on at CT. And this is definitely one of the take-home messages, is that on MRI, we can't see calcifications. What we see is typically very dark pericardium, very dark pericardium, often irregular defined. If you see such a dark pericardium with irregular borders, we already suspect that it might be a constrictive or an abnormal fibrotic or fibrocalcified pericardium. You see it also on the short axis images, the spread of the abnormal pericardium. Here are two other examples showing the location of the abnormalities and the squeezing of the heart by the non-compliant pericardium. Just a few words about calcification and constrictive pericarditis. As I said, they are not visible on CMR, but they are often present. Also a couple of years ago, we looked at this in a retrospective way, and what we found is that CT is definitely the best technique, superior to both cardiac catheterization and chest film. But the most important thing is, as I already showed you, is that calcifications are not limited to the pericardium, but may invade the underlying myocardium, as you can also see here on these T1-weighted spin-echo images, and also on the CINI images here. You see there are a couple of, you see the dark are the calcification really deeply invading the myocardium. If they are present, they may also affect both the regional and global function. If you have CT, if you see pericardial calcifications, also always look very careful and mention it into your report, because it might be important that the cardiac surgeon knows about whether or not the myocardium is invaded. And as I said, we have, this is once again an example of a classic constrictive pericarditis with really a huge impression or compression on the right ventricle. On this virtual reality images of the hearts, and we see the location, the spread of the calcifications. This is the classic example, but we have to deal also, be familiar with different atypical forms. The first one is focal. It might be very local, and you see here the thickening on the T1 and the low single intensity on the cine images, but it's constricting the lateral basal part of the right ventricle and the AV groove. We have also conditions which are considered non-thickened, such as this one, and the diagnosis here definitely directly or using direct signs or abnormality of the pericardium is really difficult. So we have to look at other things. I will come back in the next slide on it, look at the ventricular coupling or abnormal ventricular coupling. And then we have the conditions with inflammatory effusive pericarditis, and because of the decreased compliance, the filling may be also impeded. These stages, where you have a lot of inflammation, these patients should definitely, in the first step, be treated with optimized anti-inflammatory treatment and not to be directly sent to the cardiac surgeon. And finally, whereas, let's say, mostly the right part of the pericardium is involved, you have also the left-sided forms, such as you can see here, and it's really constricting the lateral part of the left ventricle. So moving from morphology to physiology, as I said, the pericardium, the constrictive pericardium impedes the cardiac filling. And what happens is, in a normal condition, you have the, let's say there's a variation over when you take the respiratory cycle and you look at the variation of the left and the right heart filling, you see some variation. But in patients with constrictive physiology, this variation is largely, substantially increased. What happens is that during inspiration, that you have an increased right heart filling with impeded left heart return, and the opposite occurs during expiration. Let's say we can measure this with CMR. If you do phase contrast imaging over the mitral and tricuspid valve, you can look at the inflow patterns. The problem is, because of true plane motion, that it's not easy to interpret them. You can do it. What we do is we use another phenomenon, which is also typical for constrictive pericarditis, is this septal inversion, inspiratory septal inversion. And how can be explained is, if you have a constrictive pericardium, if you inspire, what happens is that your right heart filling increases, and when the right lateral wall cannot go outward because of the constrictive or non-compliant pericardium, what happens is that you have or create a leftwarded shift and inversion of the septum. And this is typically occurs during onset of inspiration, during diastolic filling, and then rapidly decreases, and during expiration, because of the enhanced left heart filling, the opposite happens. So during inspiration, you see a shift of the septum leftward. During expiration, you see a shift rightward. And this we can exploit using cine, if you do real-time cine imaging. And typically, we use the short axis slice somewhere in between the mid and the basal part, and we ask the patient to breathe in, breathe out. And you will see, if I move, you see as he starts to see here, he starts breathing in, and you see the sudden septal inversion. So this is showing the inversion, and then this increased right septal shift during expiration. Finally, we can also use CMR to look at increased right heart filling, look at the size of the IVC of the hepatic veins, look at the and also T2 relaxation times of the liver. And what we nowadays do is also we ask the patient to breathe in, breathe out. In normal conditions, you have at least a decrease in size of more than 50%. And for instance, in this patient, you see during over the respiratory cycle, there's hardly any change in collapsibility or inspiratory collapsibility. Finally, there's also a role for CMR in looking at the effects of anti-inflammatory therapy. And what studies have shown is that if you have a positive response on anti-inflammatory therapy, what happens is that the intensity of enhancement decreases. You have a thinning of the pericardium, so it returns to normal. However, I would like to definitely advise you that also if you have an evolution towards an end stage fibrotic pericardium, that you also have a decrease of late gadolinium enhancement and also a thinning. Now, what you need is definitely have to look at other signs, such as the size of the atria, the presence, looking at the ventricular coupling, look at the size of the IVC, and all signs that are or might be indicative of reversed of the constrictive physiology. So let's move to congenital pathology. The most common congenital pericardial abnormality are pericardial cysts. They are, I think, quite easy to recognize. They typically occur either in the left or the right paracardiac space. You have no visible wall, and they typically fluid, and it's easy to measure the Hounsfield units on CT, to do the T1 weighted or T2 weighted sequences. You can do also the T1 mapping, but they need to be differentiated from a set of, let's say, lookalikes. Most of the time, it's not that difficult. Bronchogenic cysts typically have a more atypical wall. Mediastinal cysts are most often located in other places. Bleeding cysts or cystic timomas have a wall, of most often have a wall, and also have these contents inside. And then you have other conditions like false aneurysms. These patients had an unknown or unrecognized right wall rupture with kind of cyst or something that looked like the cyst along the right heart border. Finally, do not mistake ascites, for instance, as a pericardial cyst. But let's say most often these conditions are quite easy to differentiate. Pericardial absence is really an extremely rare condition. I think I've seen over 30 years, maybe 4 or 5 cases. It's a defect in the pericardium. It can be small, it can be more larger. How can you recognize it? It most often occurs left-sided. And what you see, and you can already suspect it on the chest film, is that because part of the heart moves through the defect, the heart is far too much to the lateral side of the chest and can really come into contact with the lateral chest wall, and is also oriented not only lateral, but also typically posterior. And the heart really has a very bizarre form. Most often you don't see the defect always, although sometimes you can say, okay, most likely the defect is somewhere here, and this is the prolapsed part. And what we did is, and what if you have doubts, what you can do is, normally we scan patients' supine position, but it might be helpful because the defect is most often left-sided to turn them on the right lateral side and to see the change in angle. And we did it in real time. So this is a real-time study where you see that we ask the patient to rotate, and once he passes let's say the midline, so here heart is still oriented posteriorly, and there he moves, and once he's over the top, then the heart falls in, let's say, a more normal position. And this is an example how you can use dynamically the CMR, or how you can use CMR to dynamically study the heart. And finally, this is my last slide, pericardial tumors and others. They are extremely rare. It's metastasis or invasion of the pericardium is much more common than primary. Mesothelioma, teratoma, angiosarcoma are among the most common cases. This is an example of an angiosarcoma, one we recently did, although this is also really very rare. I think I saw about 15 cases on 30 years, so one case every 2 years I see in Leuven. And they typically arise from the lateral wall. They grow very aggressively, and at the time of the diagnosis, it's very often already invaded in the pericardium. I see the diffuse, you see some fibrin strands, and very often they already have lung metastasis. An example of a synovial sarcoma invading the lateral basal part of the left ventricle. This is an example of a patient with esophageal cancer with diffuse pericardial metastasis and also presenting with constrictive physiology. Here, an example of a benign, this can already be recognized on CT, fatty structure inside the pericardium, very well defined. Also, the high signal intensity. I only show you the two images, but also on the T1 maps and the other images, for instance, the fat Dixon images, everything pointed towards fatty. This is an example of lipoma. Don't misrecognize sarcoma in a patient with Erdheim-Chester disease, because Erdheim-Chester has also the tendency to affect the right lateral wall, but it grows not as aggressive, so it's more smoothed. It extends towards the atrial septum, and also in more extensive cases, the aorta is coated, the coronaries are surrounded by soft tissue, and it can extend along the paravertebral spaces more towards the abdomen. So this brings me to my concluding slide. I think both CT and even more CT really has advanced towards, I would say, a prime imaging modality to investigate the pericardium. And I strongly would recommend to use a comprehensive approach where you try, and then I always compare CMR with making a puzzle. So we have different pieces of a puzzle, and by combining different sequences, you get information of the different aspects. And I think if you are able to acquire all these pieces, there's a very high or fair chance that you have a very nice view of what is going on inside the pericardium and what is the impact on the heart. So this is, let's say, more or less I wanted to talk or say to you. I once again would like to thank Robert and Haitham for giving me the opportunity to give this lecture.
Thank you, Jan. A fantastic presentation. Incredible cases all around the heart of this perhaps neglected organ, let's say.
Yeah, I fully agree.
But amazing what is possible with CT and MR, and particularly MR imaging in this regard. There are a few questions here already in the chat. I can read, for example, one by Dr. Ahmad Soliman. In case of pericarditis without pericardial effusion, are the CMR findings diagnostic, and what is the sensitivity and specificity for this scenario? So a difficult scenario, pericarditis, no effusion. Does this exist, and how accurate are we with MR?
Well, I hope I've shown and convinced you that late gadolinium enhancement really has changed our look at pericardial inflammation. I can tell you a kind of anecdote. About 20 years ago, we wanted to publish our first study on use of late gadolinium enhancement in the detection of inflammatory pericarditis. And we had, let's say, also biopsy to confirm our CMR findings. And we submitted this paper to circulation and was rejected. And the reviewers, they said, it's wrong, pericardial inflammation, late gadolinium enhancement, that's not correct, it should be pericardial fibrosis. Although we had the histology proof. And I said, no, that's not the case, it's definitely inflammation. So I sent it back. Of course, it was rejected, but 5 years later, it was a circulation paper published on the same topic, and they really in the discussion, they really mentioned what we wrote 5 years before. So sometimes you can be ahead of time and people do not believe you. But I think if you are convinced that you are correct, I think you should go against the mainstream and try to prove that you are correct. And lead gadolinium enhancement really has changed our look. And I would strongly recommend always to do the T2 weighted T2 steer, where you have really very strong T2 weighting and all the rest is dark. So the blood is dark, the fat is dark. If you have a pericardial inflammation, definitely in the acute phase, you see it. If you have the two, you know that you are in the beginning. If the T2 gets normal, this means that you are already in a later stage. The only thing where you have to be careful is in patients prior surgery. In these cases, definitely what you see is low intensity pericardial enhancement, as shown by the paper by Pavon and colleagues, low intensity, and there it's more difficult. But if you have let's say inflammatory pericarditis, or if you have a patient, if you have such a patient referred to do CMR, add T2 weighted images, because they will be helpful to differentiate between let's say a kind of low-grade subclinical inflammation and another stage. But I think to come back on the question is that at the moment we don't have any other imaging modality that is has such a high accuracy to detect pericardial inflammation.
Okay, thank you very much for this answer. I guess that this answer is also fulfilling or answering the question by Christopher Schneeweiss. In minor pericarditis, the LGE images can be quite challenging, especially when no fat suppression is available. I also use VIBE sequences, but these are not ECG gated.
Yeah, but I agree. Sometimes in very mild cases, differentiation is not always, and this is something I haven't said, but I agree that fat suppression is helpful, because otherwise it's more difficult to depict the pericardial inflammation or pericardial enhancement. But there are conditions where suspect is there a mild degree of pericardial inflammation or not. There are not really, because it's still it's a visual technique and not a truly quantitative technique. Ideally, T1 mapping could be a solution, but the problem of T1 mapping is that the spatial resolution with regard to pericardial thickness is just not sufficiently high to precisely measure the pericardium and not to be inside the myocardium or inside the surrounding fat. This impedes, I think, the use of mapping to look at pericardial inflammation.
And perhaps one last question from Rolf Kipke. We sometimes see patients that have clinically recovered completely from acute pericarditis, but still demonstrate isolated LGE for quite some time, sometimes for months. How should we deal with this phenomenon? I think it's a very good question.
It's a very good question. And most likely, these patients still show some low-level inflammation. This is something we also see. Sometimes we see patients referred with recurrent pericarditis or who had pericarditis just some weeks or months ago, where we still see some low-grade pericardial enhancement. That's correct, and this is definitely a limitation of the lead gadolinium enhancement technique. But here, I think once again, the use of T2 weighted imaging might be complementary to look at least in the more acute phases of an inflammatory pericarditis. But let's say this is definitely a good comment. it's let's say it's not a pericardial enhancement is definitely not a black and white story. You have the clear-cut cases where there's no doubt. You have the normal ones, and then you have some cases in between where the interpretation of the finding is more difficult. That's correct.
Okay.
Thank you, Jan. I hope you can hear me. I'm not able to be seen on my video. So Jan, thank you very much for really this brilliant presentation and also your dedication to cardiac imaging and especially to CMR. May I ask you one question? On pericardial fat. So what's your opinion? We see sometimes patients, they have normal, everything is more or less normal, but in some patients we see brighter LGE and less bright LGE on the late enhancement images. Do you have any idea why this is the case?
And you're speaking about patients with pericarditis, or?
No, actually they are not coming with pericarditis. They have maybe sometimes systemic disease, or they come for perfusion imaging, stress imaging, and I noticed that the signal, the uptake of LGE in them is different, and sometimes I have the impression that younger women tend to have brighter LGE in the area of the where the fat is, but I was wondering why is this the case, and I maybe thought I would ask you, but maybe it's just a wrong perception on my side.
It's difficult. I don't have a clear-cut answer. Maybe what I can suggest, Robert, is maybe send me just a couple of images that I can take a look at and see if the pattern you see, if I can repeat it or can see it as well, because this is something where we can learn.
Thank you. I will certainly do this, and I would like to learn from you in this perspective. So yeah, Jan, you're really a pioneer in this field, and I'm really honored and so happy that you joined our grand rounds. And yeah, it's always very, very, very fantastic having you here. So thank you. From my side, I'm sorry for my technical problems. So yes, thank you, Jan.
Thank you so much, and I would wish everyone the Happy New Year, and maybe it's still too early, but the very best for the end of the year. Let's say it like this.
Yeah, Jan, excellent. You are not only a perfect speaker, you also can take over the moderation, because this would have been my words now. Yeah, perfect. This is the comprehensive speaker and moderator. So yes, I think we are at the end of this fantastic lecture. We have more than 1 hour, so it's also okay now, I think. Thanks also from my side, Jan, for your willingness to participate in this Grand Round series. I wish everybody a wonderful holiday season and a Happy New Year.